Alright, this is going to be Chapter 19, the Reproductive System, Part 2. And in this one we're going to talk about the gross anatomy of the penis. Body of the penis, going to be in this location here. Symphysis pubis bone, urethra, essentially at the base. The root of the penis. Corpus spongiosum, this right here. Towards the posterior. My apologies on the first line there. Corpus cavernosum is going to be these areas here. This is what causes erection to occur. From the top, ureter from the kidneys, urinary bladder, the ductus deferens. This is coming from the testes. At the back here, we're going to have the seminal vesicles in this area here on the posterior side of the bladder. Prostate, bulbourethral glands, the urethra, and the external meatus. This is a side shot or a cross section. Vascular beds, the urethra. Collagen sheath here, fibrous tissue, central arteries here, and then the corpus cavernosum, which engorges with blood during erection. Clinical note: priapism. Prolonged painful penile erection not associated with sexual arousal. Most common result from injected medication for impotence, or let's say that you had an adverse reaction to Viagra or Cialis. Spinal injuries occur from unopposed parasympathetic stimulus for the priapism. Also in this, sickle cell can also cause priapism, and that's because the cells actually sickle. These will stick in capillary beds in the penis area and cause blood to come in but not to go out. So sickle cell crisis, sickle cell is a contributing factor also to priapisms. Hormones and male reproduction function. Gonadotropic releasing hormone. It's a peptide that's synthesized in the hypothalamus and carried to the anterior pituitary by the hypophyseal portal system. Now, if you'll remember this back from the endocrine system, the anterior pituitary releases two hormones, follicle stimulating hormone, or FSH, and luteinizing hormone, or LH. Follicle stimulating hormone. Under follicle stimulating hormone, testicular cells promote spermatogenesis and spermiogenesis. Under luteinizing hormone, interstitial cells stimulates hormones, and this hormone stimulation stimulates spermatogenesis, increases libido, stimulates metabolism, maintains secondary sex characteristics, facial hair, body size, regulates luteinizing hormone and follicle stimulating hormone at the hypothalamus. So this is kind of a negative feedback system. Quick rundown of this. So hypothalamus releases gonadotropic releasing hormone, anterior pituitary, and we get two hormones off of this. Luteinizing hormone allows for the secretion of testosterone. Negative feedback system on this will stop the release of gonadotropic releasing hormone. The testosterone has effects on the CNS, stimulation of bone growth, establish and maintain secondary sex characteristics, and maintain accessory glands and organs. Follicle stimulating hormone, seminiferous tubules, testicular cells, stimulation of spermatogenesis and spermiogenesis. Whenever that has created enough, secretion of inhibin, which kind of puts the shutdown on follicle stimulating hormone, and also on gonadotropic releasing hormone. So negative feedback systems are throughout the body. Male genitalia trauma. Rarely injured, highly mobile with scrotum, and it's fairly tough. Self-inflicted injuries compose some of these. Vacuum, lacerations or amputations, fractured penis. Cracking sounds can be heard during this because of the the way that the tissue is surrounded with connective tissue. A loss of erection will occur. Reproductive system and the female, a large area to go over here. Ovaries, Mittelschmerz, ruptured ovarian cyst, uterine tube, tubule and the uterus, endometriitis, endometriosis, PID or pelvic inflammatory disease, gross anatomy over the vagina, menstrual irregularities, amenorrhea, external genitalia, mammary glands, endocrine effects on the breasts, breast cancer, hormones and the female reproductive cycle, dermoid cysts, and then infertility in this section. And this will actually trickle over into part 3. Reproductive system of the female, ovaries, uterine tubes, the vagina, external genitalia, and mammary glands in this section. Quick general overview. We have the ovary up here. This would be the uterine tube, fallopian tube, the uterus, cervical opening, fornix back here, urinary bladder, symphysis pubis, gross anatomy on the outside, clitoral area, glands for secretions, labia minor, labia major, and this would be, this structure down here is this structure right here from the anterior view. Ovary, this is fimbriae here, fallopian tube, the uterus, cervix and cervical opening. During ovulation, we actually see the fimbriae coming down and doing a very gentle touching here, so whenever the ovary is expelled, it can travel down the fallopian tube. Alright, the ovaries. They're responsible for the production of female gametes or ova, or eggs, secretion of female sex estrogens and progesterones, secretion of inhibin, which is a negative feedback system of the pituitary and follicle stimulating production. And we're going to see that this holds a pretty big role as far as ovulation is concerned, and the adjustment of overall hormones. Oogenesis, and just like in the previous sections when we were talking about spermatogenesis, this would be egg production. Oogenesis is a process that begins before birth and ends with menopause. The female's eggs actually begin development before they're even born, and then they kind of stop and they wait until puberty hits. Once puberty hits, they develop more, and then they start a 28-day cycle, which allows them to become pregnant during a specific time. Oogonia, stem cells complete their meiotic division before birth. Primary oocytes, and these are what are going to develop into secondary oocytes that we'll talk about here in just a little while. Primary oocytes begin to undergo meiosis. They proceed as far as prophase or meiosis 1. The differences between nuclear events in the testes and the ovaries. Cytoplasm of the original oocyte is not evenly distributed during meiotic divisions. Oogenesis produces a functional ovum that contains most of the cytoplasm and up to 3 nonpolar bodies that later disintegrate. These nonpolar bodies give up their cytoplasm so that the egg that is produced, or the secondary oocyte that is produced, has the greatest ability to continue on and flourish and develop a fetus. The ovary does not release a mature gamete. Instead, a secondary oocyte is released. The secondary meiotic division is not complete until after fertilization occurs. So as we talk about this is the cellular divisions that occur. So this is before birth, and we start to develop our primary oocytes, and these are diploid. These don't have half. This thing is ready to divide again. DNA replication before birth occurs. Meiosis 1 begins before birth. synapses of tetrad formation, and this is the primary oocyte and ready to go. Now at puberty we start having menses or menstrual cycles, and from the development of that, this primary oocyte splits. However, it doesn't split evenly. Most of the cytoplasm from the secondary body here is given up and given to the secondary oocyte, which is haploid. Now this one here is ready for fertilization. If fertilization occurs, then we'll get a secondary oocyte, and then it'll go into meiosis too, and we'll get actually another secondary polar body out of this. So again, whenever this matures, most of the cytoplasm is given up to the secondary oocyte, or the maturation or the development of the fetus. Follicle development. Ovarian follicles, special structures in the ovaries where both oocyte growth and meiosis I of oogenesis occur. Primordial follicles, a combination of ovarian follicles surrounded by a single layer of follicle cells. Primary follicles. Primordial follicles enlarge and divide and form several layers of cells around the growing primary oocyte. Now these guys are what we saw just a second ago, the primary follicles. Zone of perilysidia, membrane that surrounds the primary oocyte, increasing the surface area available for the transfer of materials from the follicular cells to the growing oocyte. Secondary follicle. Follicle fluid grows and accumulates in small pockets that gradually expand and separate in the inner and outer layers of the follicle. Now this secondary follicle is what they ovulate. It's what females ovulate. This is a substantiating section of that cellular environment that allows the oocyte to flourish if it becomes fertilized. The ovarian cycle. 28-day cycle that includes follicle maturation. Follicle phase. At the start of the ovarian cycle, an ovary contains a few secondary follicles destined for further development. From this, we get a tertiary follicle formed by 10 to 14 days in the ovarian cycle, and then an antrum, which is a term. The oocyte, with the covering of the follicular cells, projects into the expanding central chamber of the follicle, which is the antrum. Ovulation. Tertiary follicle releases the secondary oocyte. Then we get something called the luteal phase and the corpus luteum. In the luteal phase, 14 days of the ovarian cycle begins with the ovulation. The empty follicle collapses. The remaining follicular cells invade, resulting in an endocrine structure known as a corpus luteum. So this follicle, or the secondary oocyte, the surrounding area off of the egg that was ejected out during ovulation with the assistance of the fimbriae, continues to further develop and develops into something called the corpus luteum. The corpus luteum is an endocrine structure resulting from the release of the secondary oocyte. If fertilization occurs, or a fetus starts to develop, the corpus luteum will stick around for about 5 to 6 weeks. And what it does is, by the secretion of progesterone, it increases vascularity to the uterine area. This assists the fetus in growing and developing very rapidly. Clinical note here: Mittelschmerz, mid-cycle abdominal pain, which is caused by ovulation. Spotting may occur, and the treatment is symptomatic. We generally treat just for the actual the abdominal pain. Clinical note also: ruptured ovarian cyst, fluid-filled objects that may rupture and be a source of abdominal pain. Pain may radiate into their back, and they may have vaginal bleeding with these, depending on where the actual cysts are. This is a quick overview, figure 1910, primordial follicles, and then you get primary follicles after this. So these primordial follicles develop into the primary oocytes, and this is the zone, the actual cellular area here. If I can draw straight. Holy cow. The cell area, zone of Pellicindia. The zone kind of develops and it separates this off. Now this right here is the primary oocyte, and as the primary oocyte drops, this is considered the atrium whenever, or antrum, whenever this area here starts developing. This is just before ovulation occurs. So this is still a primary oocyte and is surrounded by a zone of Pellicindia. If we'll look here, primordial follicles, primary follicle, which is up here. Secondary follicles, these start to develop. This is considered the antrum. Now, this is considered also a tertiary follicle. At the point that it developed the antrum, it's considered a tertiary follicle. This is ovulation. This whole structure here will turn into the corpus luteum. Now, if implantation takes place, or this becomes fertilized and implants into the uterine wall, then the corpus luteum will continue to secrete progesterone to assist the uterine wall in becoming more vascular for the developing fetus. Ovulation occurs, and then we get the development of the tertiary follicle into the corpus luteum. Uterine tubes. A uterine tube, also a fallopian tube or an oviduct. Infundibulum, expanded funnel closest to the ovary, and these are going to be an area to essentially play catch to the eggs or the oocyte. Fimbriae, fringe of tissue in the opening of the fallopian tube. Ovaries are not in contact with the adjacent tube, so when ovulation occurs, sex hormones activate the fimbriae, cause it to swell with blood, and hit the ovary with a general sweeping motion. This is what brings the egg into the fallopian tube. If fertilization occurs to the secondary oocyte, encounter spermatozoa during the first 12 or 24 hours into its passage. Quick general overall anatomy here. Uterus, the body. Isthmus, the cervix. External orifice, internal orifice, endometrium, myometrium, and perimetrium. So let's just start with the uterus here. This is considered the fundus of the uterus up top. Uterine cavity. Body of the uterus here. Perimetrium on the outside. Myometrium, which is the muscular area on the inside, this area here. If you'll notice that it is highly vascular. Broadened ligament here to the mesentery, kind of hold things in place. Have an ovarian ligament to hold the ovary intact. These are the fimbriae, and these are what generally sweep during ovulation so that the egg can get to the infundibulum, which is a funneling area. This is considered the isthmus, or a narrowing. So ovulation occurs, goes into the fallopian tube, the corpus luteum sticks around. If fertilization occurs and it implants, then the secretion from the corpus luteum will assist the developing fetus. Alright, clinical note, endometritis, infection of the uterine lining, foul smelly discharge, pain, fever, can mimic pelvic inflammatory disease. Clinical note again, endometriosis, condition in where the endometrial tissue is found outside the uterus, most commonly in the abdomen or pelvis. Management on this is going to be hormonal therapy, surgery, or anti-inflammatory drugs. Uterine cycle continue. Menses. Menstrual cycle begins with the onset of menses. Period is marked by degradation of the superficial functional zone of the endometrium or the lining of the uterine wall. Menstruation. Endometrial arteries constrict and reduce blood flow to the tissues in the functional zone. This causes the tissues to die of oxygen and nutrient deprivation. The sloughing of the tissue continues until the entire functional zone is lost, and that's approximately 1 to 7 days. The proliferative phase begins with the days following the completion of menses. The surviving epithelium multiply and spread across the surface of the endometrium, the internal liner of the uterine wall. The secretory phase, the uterine glands enlarge and increase their rates of secretion as the endometrium prepares for the arrival of a developing embryo. Clinical note: pelvic inflammatory disease is an infection of the reproductive organs. Chlamydia, strep, staph, gonorrhea are a few examples of these. The vagina. The vagina is an elastic muscular tube that extends between the uterus and the vestibule, which is a space bound by the external genitalia. The fornix, a shallow recess that surrounds the cervical protrusion. Hymen, urethral meatus, partially or completely blocks the entrance to the vagina before the first occasion of sexual intercourse occurs. And quick rundown on this again. Last time we'll be seeing this. Fornix right there. This is the cervical opening. Cervix, ovary, fallopian tubes, fimbriae, symphysis pubis, glandular areas for secretion, vaginal area. From the front, uterus at the posterior of the vagina is the cervix. Behind this would be the fornix, ovary with supensitory ligaments, fimbriae, fallopian tube. If implantation occurs, once the secondary oocyte gets liberated under the effects of the corpus luteum, which will still be developing, if fertilization occurs, this egg will travel down and implant into villi that are in the uterine wall to where it will set up shop and grow. Menstrual irregularities. Dysfunctional uterine bleeding commonly occurs when ovulation has not occurred. Amenorrhea, stopping of menses for more than 6 months. Dysmenorrhea, pain associated with the onset of menses. Clinical note: amenorrhea. If menarche, first menstrual bleeding, does not occur by the age 16 or a normal menstrual cycle becomes interrupted for more than 6 months, then you have amenorrhea. Things that can lead to this: malnutrition, no uterus, genetical disorders, women in training, or that may be marathon running. That would be because of the secretion of other hormones. External genitalia. Perineum, external genitalia, vulva, vestibule, labia minor, clitoris, lesser vestibular glands, greater vestibular glands, mons pubis. Symphysis pubis or mons pubis, clitoral area here. Urethral opening, if you're ever starting a urinary catheter, be sure it's under the hood. Hymen, if it's there. Vaginal entrance. Labia majora, labia minor. This ends part 2. If you have any questions, feel free to contact me. My name is Roy Smith. 405-219-7613 or smithr@imsa.net. Thank you.